Chapter 2 Gastronimaa. Neuroendocrine tumor secretes gastrin. Neuroendocrine markers, chromogenin, and clinical manifestations like Solinger-Ellison syndrome. What are types of gastronimaa? Sporadic 80%. Features. It is the second most common pancreatic neuroendocrine tumor. It is single large tumor. The age group is 30 to 50 years. Sex more in female compared to male. Malignancy risk is 60%. Metastasis to liver. Location is Passaro's triangle or gastronimaa triangle. What is Passaro's triangle? Passaro's triangle is a point. The point A is a junction of cystic duct and common bile duct. Point B is a junction of second and third portion of duodenum. Point C is a junction of a body and neck of the pancreas. Treatment. How do you treat sporadic gastronimaa? Majority through surgery. Prognosis. It's very bad. It becomes more aggressive. Note. Most functional pancreatic neuroendocrine tumor is insulinoma. Associated with MEN1 is 20%. Sporadic is 80%. Associated with MEN1 is 20%. What are the features? The most common neuroendocrine tumor in MEN1. It is the most common neuroendocrine tumor in MEN1. It is multiple and small tumors. Age group is less than 20 years. Sex both equal in both male and female. It's autosomal dominant disorder. Malignancy risk is very low because it is mostly benign. Location is duodenum. Treatment: high dose of proton pump inhibitors, more than 2.5 centimeter surgery. Prognosis: it's good, less aggressive. Most common cause of death in MEN1 is enteropancreatic neuroendocrine tumor. So this is Passaro's triangle. Effects of increased gastrin. What if the gastrin increases? More gastrin leads to stimulation of the parietal cells, and which increases the HCl secretion, which may either damage the mucosal lining of the GIT and cause gastric or duodenal ulcer, or acid inactivates the pancreatic enzymes and causes diarrhea, steatorrhea, and malabsorption. Clinical features. Most important symptoms are abdominal pain. Most common manifestation is peptic ulcer disease. Indicators of gastronimaa in peptic ulcer disease. Unusual location is second part of the duodenum and beyond. Refractory to the medical therapy. Gastric ulcer more than 12 weeks. Duodenal ulcer more than 8 weeks. Recurrence is possible. Then abdominal pain leads to diarrhea. Note: diarrhea in gastronimaa is both osmotic and secretory, has both osmotic and secretory component. Osmotic due to malabsorption. Secretory it is due to tumor or some toxins. Secretory gastrin, it acts on enterocyte, absorbs water into the lumen and causes diarrhea. In osmotic, there will be increased acid secretion, and which inactivates the pancreatic enzymes, and it increases the lipolysis and causes the steatorrhea. How to manage gastronimaa? First, do investigation. Fasting gastrin level. It is a screening technique. 1000 picogram per ml means carcinoma. 200 to 1000 is means you have to conduct the confirmatory test. If it is less than 200, then it is normal. Secretin stimulation test. It is the confirmatory test. What is the principle behind it? In gastronimaa, secretin stimulates gastrin. Physiologically, secretin inhibits the gastrin secretion. What is the procedure? If you give IV secretin, measure the screen gastric uh, screen gastrin at the regular intervals. Rise by 200 picogram per ml means it is gastronimaa. SRS, somatostatin receptor scintigraphy. Octreotide scan should be done, also called as octreotide scan. Somatostatin receptor scintigraphy, also called as octreotide scan. It's an investigation of choice and more specific. What is the principle behind it? Gastronimaa, due to gastronimaa, there will be increased number of somatostatin receptors, hence octreotide used in treatment also. The procedure is you have to give radioactive labeled octreotide, and we should note that the somatostatin receptor scintigraphy not effective in small tumor or MEN1. For that we should do endoscopic USG instead. What is basal acid output? The basal acid output should be more than 0.6 in gastronimaa. It is BAO. What is MAO? Maximal acid output. The investigation in the pheochromocytoma is done by gallium dot at 8 PET scan. Treatment: men associated gastronimaa, you have to give high dose PPI 60 to 80 mg. If size is more than 2.5 cm, then go for surgery. Sporadic, you have to give high dose of PPI plus octreotide followed by surgery. Surgery based on location. Pancreatic head enucleation, pancreatic body or tail, distal pancreatectomy, duodenum full thickness exclusion. Note: gastrectomy, it is not required. The most common site of metastasis is liver.